You guys were that one suit, not just scrubs.
Good question. So in COVID, I'll talk about it. We changed to scrubs because it was big contamination, but supposedly it's fireproof. So fireproof boots, fireproof flight suit. We're supposed to wear gloves, but since COVID, we haven't been wearing fireproof gloves and then helmets. So theoretically, if there's a fire, it'll buy us a couple seconds of not being cool.
Yeah.
So that's why. The other thing is they're hugely identifiable. Everybody knows who we are.
Are they hot?
They're hot in the summer, cold in the winter, and they're itchy all the time. So, and then think about if you're a girl, you have to go to the bathroom. They have actually day one of orientation is how to go to the bathroom in flight suit. So yeah, it's like lay out a towel, put it all down. It's a big deal. There's a bunch of guys that work with us, so it's pros, and especially our old Vietnam pilots that we used to have. It was a process.
I think I just need to get out of the view. Do you want this
I'm cool.
another way? I just feel bad, like you're bending over.
No, I'm good. If this works, yeah.
Okay, cool. We're ready. I think so. I think this is everybody.
So I'm Jeff.
Let's say you want to go ahead and introduce yourself. Okay, thank you.
I'm Jeff. Things were not in place for this because it seems like there were all these interruptions for it, but we're here now. So Liz takes her nursing students down every semester and is very good to us. So when she contacted me, I'm like, sure, I'll come talk to you guys. If you have any questions, let us know. This is not going to make you smarter physiology wise. I got C- in physiology. You don't want me to teach you physiology. This will be what we do, how we do it, and some of the patients. That's the best way I could describe from what Liz kind of requested. We'll talk about a little bit of pathology, what we've seen. But to explain what I do, I just decided to just do the last 5 transports I did. So not counting the last 3 transports I've done. So I was really excited when we moved here. They actually had billboards for survival flight. So I got a job because we moved out to Livingston County. So we used to run 2 helicopters out of here. Right before I started 17 years ago, they said, let's move closer to the people. And actually St. Joe's had a helicopter at the time. They were moving it out there, so we blocked them. So we'll see what happens. But I literally was like super excited because survival flight actually had billboards. This is our plane. This is me. So I have 3 jobs. I work here. I work at West Michigan Air Care as a flight nurse as well. And then I'm starting to work at SWAT too. And I'll start there. I always talk about kind of what starts because I bought a new house. So I have 3 jobs because I like tractors, and that's our new barn that I paid way too much money for. So what we're gonna do, this is essentially consider this like a QA. So that's how I can present the actual cases. So consider this a QA, consider this a process improvement. That's how I can talk to you about patients. I've changed some of the data just to make them a little bit de-identified, but just consider this like a chart review. So that's what all this says to keep me from getting fired. So where I start, I always start with talking about kids. So part of the barn is my son bought a bounce house business. So he just got this yesterday. It's awesome. So it's a license to print money. They make a lot of money doing that. My other son's a welder. We're working on that at Washtenaw. And then my favorite one is the youngest. She's going to be an actress. I'm sure of it. So that was last year. She's even prettier this year. So I always have to show this off. But the cool thing is she does princess parties for rich people in Oakland County. And I'll skip it. But yeah, she is really good. So the other thing she does, one of our medical directors needed, so they wanted to practice amputation. They actually were really well supported. The engineering students made a fake leg with skin and meat and bone. And they wanted to work with the fellows on somebody that was hard to cut their leg off. So Tina, the medical director, came to me and she's like, your daughter's really pretty. Can we use her? So just 2 weeks ago, Lucy got an acting gig. She got Lululemon stuff from Tina, so she was very happy. But they had to cut her leg off. So she got to act in that, and she passes out when she goes to the dermatologist. So it was kind of a big thing for her to not, keep it all together. But my kids have grown up in this. The other good thing is my wife grew up as her dad was a firefighter. So she understands all weird hours and stuff like that, me getting late, me being always gone. Because I think a lot of spouses have a hard time with what we do because our hours are crazy. Where do I start as well? This is my little friend. If I get forgotten for everything, I want to be remembered for showing little kids helicopters. That's my whole career. I'm good with it. So start, what do you need to be a flight nurse? We're hiring right now. 5 years of experience, but the math is 2 years of PICU, 2 years of ER, 2 years of adult ICU. So that's more than 5 right there. It's an ambulance. So you have to be a paramedic to be on an ambulance. So we have to be dual licensed as paramedics and nurses, which is painful. A lot of us started out as nurses and went back to paramedic school. Some of us started as paramedics and came to nursing. It gives us a nice, like today we just came from that car wreck. Mike my partner was a paramedic long before he was a nurse. So he's very much more comfortable. Some of our ICU nurses that are used to tidy and clean hate scene calls because they're chaos. So we like to build the better mousetrap by building two different people. So survival flight, a lot of flight programs, you work in RER, you work in RCU, ICU, and then you come. So you have the same person on every flight thinking the same way because they've all been taught the same way. What we like is a mishmash. So like Mike has his nurse practitioner. I did neonate. Mike worked adult cardiology. I hate adult cardiology. So we work together and we're smarter as a team. And then during the day, we also have residents that fly with us. So the ER residents come along as well. And then just kind of background wise too, the neonate team brings their own people. ECMO, when we go on ECMO, we bring ECMO techs. We always want to bring the smartest people in the room. And then if there's OB, which we do maybe one a year OB, we beg to have an OB doc too, because we don't like that at all. So I started little town of Cedar Rapids, Iowa. I wanted to be on their flight team. As you can see, this is a super dated picture. That was cool to me back in the 80s. And then I was on a fire department. Then I did neonatal transport. And then in 04, right after my daughter was born, Iowa sent us here for the ECMO class to learn from here. Lori Jacobs was in my class, who was one of the flight nurses. She showed me around, and about 6 months later, I was here. This was so much better. And my pay doubled too. So scrubs, question about scrubs, question about what we do. So that was 04. We learned a lot in H1N1. We weren't great at event management as a flight program. During H1N1, we got really good. We hired some people, Ted Edelman, Sandy Schmidt, really good people. I took Mike Snyder's position. If you guys all probably know Mikey, I was actually Mike's replacement, and he was always so genuine to be and very, very nice. So we kind of hung out, kind of laughed about PPE, didn't really think much about it. And then 02 came, and all of a sudden, 20 came, and you guys kind of know what happened there. So this is a standard configuration for a pre-ECMO COVID transport. So we bagged everything up. We brought everything we could because we were going into like Sinai Grace. It was like a war zone. Nurses would cry when we'd get there. Ventilators, they were using home vents that literally were having like dirt and filth come out of them because that's all they had. So we were like the rescue. We were doing almost like scene calls at Sinai Grace because these people they were overwhelmed. So what we did was we usually do 2 nurses and then whoever else we bring. For COVID, we actually shut down one of our helicopters and went to a 3-nurse team. So 1 was the charter clean person and the 2 were the dirty people. So we kind of did the 4th person stay back and charted. So we could do a lot more with 3-person teams and 1 back than we could with 2-person teams. Because that one at home was doing all the logistics, all the cleaning, all the charting. So by the time we got back, that person was fed, clean, and ready to go. So that person would be the inside person. And we just did a relay basically, and we could do 3 or 4 a night, which we did. And that's what Dave looked like after transport. And I think we all felt that way. So that was our last year. So it's been a weird year, as you all know. So what also is survival flight? It's the team. We have mechanics, we have dispatchers, we have 5 medical directors. 1 of them's peds, 4 of them emergency medicine. We do rounds every Tuesday. So we do 1 of the meetings you guys all go to. And then 3 of the weeks we take our best cases and then we have to present them in a medical model to the docs, both right and wrong. The docs are easier on us than our peers. We expect a lot out of people when they present. So we take, and it's crazy and I'll kind of talk about what we do. So those are 3 of our medical directors. Tina, who I talked about, borrowing my daughter's leg. Dr. Lowell is our main medical director. He's both internal med and ER. Ben Basson runs the EC3. He does it because it's interesting to him. He's like, of all the meetings I go to in a week, this is the only one I enjoy. So he really likes our rounds. And then we've got Stu Braden. Training wise, we train simulation wise. I'm not going to play into this because it's going to be, but we actually compete in simulations, or we used to. So we'll send 2 people to competitions throughout the country and compete against other flight programs. The Canadians accused us of cheating because we won too many times. So we kind of took a step back. And then what do we have? So we have 3 of the EC-155 helicopters. One's constantly maintenance. So they're probably 10 hours of maintenance for every hour of flight is what they're getting to be. So we probably need new ones. We have our jet. Most of what we do with our jet is organ procurement. So we'll do patients to the UP, things like that, but probably 80% of the plane's flights are to go get organs. Either just going to get a box and then coming back, or they'll bring the team and they'll harvest. And then we figured out too, ECMO, balloon pumps, big devices, there's nobody doing them anymore. We're the only people in the state that do balloon pumps and transport. So we needed something that we could actually have space for and secure things. So we built, with HVA, we built a ground ECMO / device / long distance transport. The big thing for us is BiPAP. We have a Sentinel case for us that wasn't ours. We refused a patient on BiPAP. It was pulmonary fibrosis. They're going to die if you intubate them. We can't intubate them. We're like, we can't do this. The ambulance got to Marshall from Indiana, ran out of oxygen with a 41-year-old that was on BiPAP. She arrested. We sent one helicopter, we sent a second helicopter with nitric, and she died. So we actually have liquid oxygen in all of our equipment because we do not run out of oxygen. That's like a rule. So that's why we built everything the way we did based on that, horrible experience. It wasn't even ours. So finally, what do I do? So my sister's a third grade teacher. And at the beginning of the year, she sent me this picture, and her job is to keep chaos out of organization. Everything's in its place. So that night, I'd actually had a flight to Kalamazoo. So I sent her back this picture with blood dripping out of the bottom of the helicopter, and she was mad. But it kind of comes to me that she keeps chaos out of her order. We find order in chaos. So that's kind of our job, is to walk into a room, be confident, not be arrogant, be nice to everybody, because we represent the whole hospital, and try to find organization. Sometimes it's just a different person walking in the room with a fresh view that helps that patient. So we really try to be very careful about how we present ourselves, because it's a big deal. We represent 10,000 people. And then I work at West Michigan too, because it's fun. So this is at the university, our mission profile is 40% pediatrics. And then of our all transports, like today we did a car crash, that's like less than 1% of what we do. So over at West Michigan, it's 3/4 of what they do is car accidents. So it's horrible to say, but it's kind of fun. It challenges you in a different way. And sometimes you even have to spray the inside of their helicopter off with a hose, which makes maintenance very mad, just so you know. But look at that. What else we do is there's lots of blogs, lots of things. But we're basically resuscitationists. We walk in and we resuscitate people every day. If some people do a code once a year or once every couple of years, we don't code people in helicopters usually. Our arrest and flight rate of 1,500 transports a year, we maybe do one CPR in a helicopter. We either stabilize them, we leave them there and be surrounded by their family when they're dying. The last thing we want to do is drag a dead person here where they're not, family's not here, horrible, they're on their way by car, they meet their dead family member. That's a disservice. So we don't want to waste those resources, and we want to do the right thing for the patient. So if somebody's not transportable, we're really defined on what that is. We'll leave them, or we'll stay with them till they pass, because it doesn't make any sense to bring people that aren't viable here. So how does this all start? What we get is a dispatch. So that's what our dispatch sounds like. The pilot checks the weather, which we'll kind of talk about. So for ICUs, we actually get a formal report from the nurse. For ERs and Cs, we get in the helicopter to go. So we can be gone in about 8 minutes. There's 2 engines, one battery, so they can start one engine, wait for the battery to recharge, and then start the other. So it's kind of a delay just to do the paperwork. The other thing too is our pilots are vended through another company, so they actually have a second pilot check. So 2 people are looking at that flight every time. We copy, we head to the helicopter, and then on the way to the call, if the pilot says it's okay for weather.
Copy, weather's acceptable. Hillsdale ER to Bronson, Kalamazoo. Patient weight 19 keys, 19.
So they'll tell us basic stuff before we leave. They will not tell the pilot before we get because we don't want them to be contaminated by the fact that it's examined. And then on the way, we'll get our scoop.
156.
Yeah, 19 kilos. Do you have any other information?
5-year-old male, 05, male, respiratory distress. Last we heard from the ER, they are intubating, and you're now going to the PICU at Bronson, Kalamazoo.
So that's what we'll know. That's kind of our scoop. From there, we do a lot of math. I'd rather have paperwork ready and know what doses are. So we figure out kind of a code sheet on the way there. And then we copy a lot of people's homework. So we have UpToDate, which if you guys don't know, UpToDate is the best resource ever. We have our own app that has all of our protocols, all our guidelines, and all kinds of cheat stuff. And then we run on guidelines. So we are very, very specific about, we are nurses expanding a role. We're not going out and doing things by ourselves. So we talk to the docs, we interface. We don't, the last thing we want to do is be a bunch of cowboys. So we're very respectful of our place, but we kind of know where to walk that line. And then we end up at places like this. So this is Hillsdale. They literally have a place to tie their horses up outside of Hillsdale's ER. So when we come back and they're like, oh, Hillsdale didn't do this or that, I'm like, they tie horses up there. And the other weird thing is, every time we go in there, it looks just like Marty McFly's downtown. Every time, like, we are literally there. So this is me a long time ago. But what the content of the lecture really is I want to tell you about the last 5 flights. Literally, these are the last, except for today. The last flights I did at the university. So I'm just going to get down so I can see my writing. So the first one is a 63-year-old, dizzy and frequent falls. It seems kind of weird that that patient needs to fly. That's like a BLS, nursing home transport. Second one was a 9-year-old who just ate McDonald's that loves cupcakes. And she was floor to floor, which I'll talk about in a second. We don't do that very often. Third one was a 17-year-old riding a bike, got hit by a car at 55 miles an hour. We had to go by ground. The third one was a 33-year-old with AML, sepsis with bone marrow transplant. Her temp was 104.4, and she had sepsis with vasoplegia. So vasoplegia is something we fight all the time. We've actually got angiotensin II now. So we got, epi, levo, vaso, and now we've thrown angiotensin II in, which is cool. It's basically everything an angiotensin II blocker does, it does the opposite. So it's a new drug that we're using to try to stabilize blood pressures as well that nobody has. And then a 75-year-old with unequal, chest pain, unequal blood pressures in his upper extremities. It's a dissection. We do 1 million of them here. Other hospitals hardly ever see them. So we're not going to talk specifically. So why does a guy that's dizzy and falls frequently need to fly in an airplane? So the big thing is, that's what his brain looked like. So you guys can see this. That's what his brain looked like 6 months ago. I couldn't get an MRI to show. It's 2/3 bigger now. And he's there talking to us. We had flown him with that. And go back to that. We had flown him with that 6 months ago. He actually recognized my partner, and he was disappointed because Mary's very nice and very cute. And he's like, "Where's Mary?" And I'm like, "I'm sorry, I'm not Mary." But he was a really nice guy, played the guitar, was coming down for an eval because the place he was up north, see it and go, "No, this is bigger." And he's herniating, by the way. But he's awake and alert talking about guitars. So some of the big things we do in Flight 2 is we're kind of the first people that they see. I've gotten to know some of the people in Gift of Art. This guy's a guitar player, loves guitar, loves everything about it. So I emailed the guitar player from the Gift of Art. So he went up and saw him. So the most important intervention I did for this patient was have a dude come play guitar with him. Sometimes it's the simple stuff. So this is our next one. So this is our 9-year-old. Our 9-year-old. This is us landing at Royal Beaumont. I don't know why the girl who took it has like advertised this on her video. But that's coming in. So the cool part was we walk in, she's walking to the bathroom, which we don't often see in our job. And she's like, "I think I'm gonna poop." And I'm like, "I like her already. She's cool." So she had just eaten her McDonald's, she's just hanging out. We could roll our eyes and say, "Why are we flying this 4-status patient?" So she was very nice, very cute. She had a congenital heart defect, a lot of facial stuff. Her neck was very short. You guys kind of are probably connoisseurs of necks too. She was a horrible intubation, and she had just passed out of home and got CPR about 12 hours before transport. So she was coming to us for peds cardiology. Super sweet. Sometimes we fly patients because I need to talk to them rather than they, she didn't need to fly, but she needed somebody to watch her super close that knew what was going on. The other thing, just kind of to say it, we don't fly parents. So the dad was kind of upset at us, but it's like, we tried it, doesn't work. Other programs in the region will actually put the parent up with the pilot, which we think is horrible, because if the parent does something unexpected, the pilot has to deal with it, which is not what we do. So in order to keep the patient safe, we do that. But she liked rainbows and she liked unicorns and she liked everything. Also, she had pulmonary hypertension. Also, the catheter and her PA pressures are super systemic. And also she's now in palliative care hospice. So this little girl that walked to our cot had a change in goals of care. So we kind of get used to it here, but Michigan sick is a different kind of sick. So, other flight programs would be, whatever, but sometimes we fly patients on potential. And this, unfortunately, she's a doll, and it's not fun to read her social work notes because the parents are going to have a hard time. So she's in palliative care now. Next one, 17-year-old. This one's kind of an obvious. She got hit by a car. Things don't work well. The big thing, if you can see her pelvis or lack thereof, think about a pelvis, just to kind of talk about that. Chris Wagner, who's our trauma director, explained this to me. It's like when you bite into a lifesaver, it always breaks in two places. Same thing. So her pelvis broke here and her pelvis broke here. So the interesting thing is she got flown from a car accident to Saginaw, Brownsville, Saginaw. She got to a big hospital in Saginaw where they don't have platelets. So many hospitals in the state are not having platelets to give, even trauma centers. So that was a complication. The other thing too, she's 17, but they didn't have orthopedics that would touch her because she's peds. So she had to wait 5 hours for us to get there by ground because they didn't have anybody to take her by ground. There's a national paramedic shortage that's going to get worse. And also they didn't have peds services for her. So she had this huge busted pelvis and pressures in the 50s. We called a little bit of report. They actually took her to IR and ablated her internal iliac arteries while we were on the way, which helped a lot. And then she was transported to us. We gave her every drop of blood. We carry blood, and then they have cross-match blood as well. And the big thing wasn't the, this is her injuries. The big thing that her pelvis, our complication on the transport wasn't that her pelvis was cracked or that her femurs were broken. And honestly, she was so unstable, they didn't even know that when we got her. So she was 10 hours out before they even realized her femurs were broken because they didn't image her here there because she was so unstable. She had a head injury too, which stinks. But our biggest crisis on transport, we carry 2 units of O negative and 2 units of FFP, which is great, but she needed more. So the problem we're having now is everything's Epic based. So if you guys give blood, you scan it, question mark? Is that what you guys do for process? You don't have that paper you fill out anymore?
The OR does.
The OR does? Okay, so they have process here. That's what I was kind of curious about, is every hospital is different now. So we got this blood, we're super happy about it. And for some reason we thought, let's look at it before we go to make sure it's right. Well, we have this young female with A positive blood. If we would have gotten to the ambulance and not checked it with their scanner, we would have had blood. We had no idea if it was hers or not. And the last thing I want to do is give blood to somebody that it isn't right. An hour away each way from any help. So that's a kind of a crisis, or kind of a challenge we're dealing with now, is how do you figure out if they've talked across the patient, how we can give it outside of their environment where everybody does it different. So that's a lot of what we do too, is send emails and say, help me figure this out, because this is more complicated than I'm used to. So Epic, great, wonderful. So next one, 33-year-old, she had AML. So she was diagnosed in December. She has a 9-month-old and a 3-year-old and a husband. And so she had a bone marrow transplant in March here. And so she was fine, doing great, doing okay. What we didn't know is she was re-diagnosed with relapse 3 days before transport. They didn't tell us that. And then her son was sick with a cold, and now her temp's 104 too. So good news, bad news, kind of bad news. White counts up, no platelets at all. So she's sick. So we walk in and she's basically in vasoplasia. They did a great job at where we got her from. They'd given her 3 antibiotics. They'd given her fluid. They'd followed the sepsis algorithm. They had done what they needed to do. She was wicked sick looking, but maintaining her airway enough. And that's our big thing, is if we put breathing tubes in people that are shocky, it's not like they've been NPO and get tanked up on fluid. We can kill somebody intubating them. So we kind of rode with her, even though her pressures were 60s and 70s some of the time of transport. We made sure the ER knew how sick she was and that they needed to kind of get on her as soon as we got there. So they had done everything right for her. The other complicating thing is, with the EMS shortage, we had 2 EMTs in the front. That's literally what they did to the ambulance as we were going over a bridge in Battle Creek. So I was like, we're going to roll over a bridge, because Battle Creek doesn't have a helipad, so we have to land at the airport in ambulance. So that's the thing too, is sometimes we put patients in ambulances and then we're not really sure who's driving. So we have to be very, very careful about that. So we actually pulled over, the senior paramedic said, you guys are switching. So the other 13-year-old paramedic or EMT drove us the rest of the way. But that's something we have to always be vigilant about, is what we do is super dangerous. So we have to be, they bounced that thing right over. We had to make sure the wheel was actually round still. So as we landed, her pressure went to 73 and her heart rate was up 124, which is, of places to have it happen, it's good to happen on the helipad. The other thing was she got super restless and she had to poop. So seems like a theme this lecture, but when people get anxious and then I can't breathe, I feel trapped, she's doing better or worse. Yeah, she got intubated right after we got to the ER. The crappy thing is, I'll do this quick. So this is, and just to present it, this is from Up to Date. The things that can make bone marrows fail is everything. The list of things that can make a bone marrow fail are 10 pages long. So she ended up having graft failure and not sepsis. So she was actually attacking her bowel. So she had free air in her bowel. She was horribly sick. So what looked like sepsis was graft failure. And unfortunately, when you open Epic and get that box, it's never a good thing. So she actually passed away about 5 days ago. So unfortunately, a lot of what we do is, Medicare has a 0 to 5 scale, how sick. We run like 4.5 to 4.75. We bring sick patients. And that includes the patients and the average that walk to the doc. The last one, 75-year-old, his wife had just died 4 days before. He had some chest pain, family was with him. He became unresponsive at 2 o'clock in the morning, and EMS brought them to a small hospital. So we launched thinking we were going to go get a dissection and bring it back here. I don't know if you guys deal with the dissection in CBCs, but it's a 14-hour surgery. So they have to make sure docs are available. So that's a big logistics thing. So we launched because they can't stay in Port Huron. So we launch, we get going, and then all of a sudden, every hospital in the state of Michigan has turned this guy down. So the hospital calls Cleveland and like, we'll take anybody. So we're now going from Port Huron for an hour and a half to Cleveland by helicopter. Logistics on that are hard. His dissection is top to bottom. It's huge. And then this is an ultrasound we didn't get, but I'll show you ones we get. So we added point of care ultrasound. So we have iStats in the helicopter. We have ultrasounds now. We have a really good ventilator. We do nitric oxide. We do balloon pumps. We do impellas. There's a lot, of things that we do that we have to keep training on. But he had this huge dissection. We walked in and we did not have any blood pressure. His pulse ox wouldn't pick up. His head was purple. But the bad thing, the good thing was he was reaching for the tube and almost falling commands. He wasn't quite falling commands, but he was definitely in there. So it's like, even though he's completely shocky, he's still awake, aware maybe. So what do you do with that? So I went out and talked to the family, and the local doc was actually his next door neighbor. Talked to the family, and I always do a 0 to 10 scale. So 0 being not being sick at all, 10 being sick. It's just something I think the families can understand of how sick your family member is. So I'm like, 0 being not sick, 10 being horribly sick. Your dad's a 13. He is beyond the scale sick. So the cool thing is the doc kind of intervened with them and said, we're going to make him DNR for the ride if he survives the ride, because there's nothing we're going to do for a ruptured dissection route. So if he survives the ride and gets there, then you'll rescind the DNR and make him, then he'll go to surgery, which everybody was complete agreement with. This was the echo we got. So this is clot, and that's blood. So look at this little slit of something. I'm going to explain that in a second, but we'll talk about that. So he had no blood pressure that we could obtain, no pulses. He was sweaty and pale and cold. And oh yeah, he was on Xarelto too. So that helps everything. So we're in the middle of it. Remember Tina that cut my daughter's leg off? She texted me literally in the middle of this and said, what's Lucy's address? She wanted to write a thank you. I'm like, call me. So like I said, we're really respectful of where we're at. I was like, before we put this dude in the helicopter and take him an hour and a half, we want to make sure our decision-making is sound. So she called back, and then this is the text she sent after, I hope the wind's good. We had Dr. Hansa, I think in Hartman, that worked in the ER. We'd call him back and it's like, good luck. I'm glad you're there, not me. That was some of our medical control. So, she's like, I hope the jet fuel works well for you because this is big. So en route, patient, we had no vitals. We had no SAT. So his level of consciousness was about the only thing we could monitor to see if he was in his end-tidal CO2. Well, about halfway there, his end-tidal CO2 fell and he stopped moving. So we're like, now what? So we actually did a needle pericardiocentesis on him in flight, which is it doesn't happen often, but we've done 2 of them in the last month. So survivalflight's done more pericardiocentesis than the ER residents combined. So we drained him. And I don't know if you remember that little slit that we saw before that I pointed out. Look at this big pouch. That's his right ventricle. So by pulling out 45 cc's of fluid, we gave him a right ventricle, and now he can perfuse a little bit. So all of a sudden he had a pulse ox pleth. His blood pressure was 97. And we're like, oh, so our hands were shaking. But when we made the decision at work, the problem is you're on Xarelto and you're bleeding, and that's just going to fill back up. So that's the complication of what we do is, some of it's just temporizing. So we got there. I'm going to show you this because it's cool. I'm going to talk about our blogs later, but I'm going to write a blog on this. Pericardial blood doesn't clot. I think it's a fibrin thing, but I want to learn more about it. So 2 hours after the transport, that blood was still in the syringe, not clotting. So we obviously got to the right spot, or the Xarelto was working, one of the two. But it's interesting what we do. It's like, whoa, we did that. So the good thing is we got to Cleveland Clinic, landed, gave him some sedation because he was moving a lot, and got him downstairs. We literally got to the floor his ICU was on, got off the elevator, he bradied and went into VFib. Like, dude. So, he chose the right time. And he was breathing, even though he was in VFib when we got to the ICU, and we're like, your guys' call, we can either run this or not. And they're like, no, we're not going to do this. So unfortunately, the son had to arrange, to have his father come back, so he had to bury both his parents, which stinks. So we're very, very careful. The other interesting thing is we don't pronounce. So even though they're dead, we have to be very careful to say who pronounced them, because dead and dead are two different legal things. So cool thing was we got to fly over Cedar Point on the way home, which looks like a lot more fun than. So that was my week. And that's not even my West Michigan stuff. So I did 3 scenes at West Michigan. That's a car upside down. It's for fun. So it's fun. We're adrenaline people. We get really dysfunctional when we get bored. And then the real reason, I don't know if you guys saw this, I don't know if you can hear it, but the real reason, let's see if we can get ready to work. You know, we make friends with people, you know. So this is Ray.
That just came in to see Dad. And they took Bill and I down and showed us the whole shebang inside and outside the helicopter, the protocol they go to fly. And they're just leaving and they said they're gonna fly by Dad's window. And there they are.
No, that was the cool thing. Yeah. And then he cries. This is the hard part. Ray was the sweetest man. He's like totally balling. So Ray always wanted to meet us. And Ray got chemo, and his nurses up on the floor just said, hey, I don't know if you guys do this. So Lori, who showed me the helicopter initially, she's like, can we go up with me? I'm like, heck yeah. It costs nothing to be nice. It costs nothing to help people get lost when they're found. You know, this guy just was interested in what we did. We became good friends with him. He passed two months after we became friends with him. But he was just a sweet guy. Very cool, very nice. So that's what we do. So last thing, just if you're interested, we have a blog. We kind of take the cases kind of like I presented, and we take the best case of the week, and it's kind of a punishment. But we write a blog on the most interesting case of the week. So it's Transport at Michigan, or Critical Care Transport at Michigan. So we have a blog. If you guys want to read what we're up to, you're welcome to do so. We put a lot of work into those blogs. So if you're interested, you're welcome to watch. The last one was on, we had a run of pregnant COVIDs. So the person who won for the week had to write the thing. So any questions? Yes. That's my notes from our car accident. I don't want to lose them. So I didn't want to take them off. But, you know, there's not a lot of places to write stuff. So it comes with us and we don't lose it.
And why the shortage of paramedics?
Because they make, so you can work at McDonald's and make $12 an hour. Or if you go, my son was talking about it. I'm glad he went the direction he did, because he got his basic in high school. He was going to be a paramedic and a firefighter and all that. So a starting paramedic at HVA makes about $17 an hour. The starting paramedic anywhere else makes $12, $13 an hour, which is, and if you go to LCC and get your basic, it's $8 grand. And then if you get your paramedic, it's 24 grand plus 2 years of living expense. So you're $40,000 into a paramedic education to make $13 an hour and work 80 hours a week. Just, yeah, all that stress, all that exposure, all that back injury. It's a young person's gig. It's a great gig, but it's a young person's gig. So I can go to nursing school and start at what, 28 now an hour, or I can go to medic school and make 17. Nobody wants to do it. So we fly now. Hillsdale's a good example. They can't find an ambulance for 14 hours to fly a TIA patient. She's 100% better. Everything's cool, but it's going to be 14 hours so they can get an ambulance for her. So we end up flying people that don't need to fly just because they need to be somewhere. It's big. It's a big, bad problem. And it's only going to get worse. They graduated, Battle Creek graduated 3 paramedics last semester. So yeah, more than that broke their, hurt their backs at HVA. So it's a big crisis. It's the healthcare crisis nobody sees. The UP, they're having, 3-4 hour response times to the UP because there's nobody up there that wants to be a paramedic in the UP. So it's a big deal. So any other questions? Appreciate you guys having us. I'm sorry that I was a little late. Yeah, you're very welcome. I hope that was something that helped you guys.